So here's the scene. First night on call as the resident in charge of the entire medical service for the night. My white coat's got 6 beepers, 3 granola bars, and maybe 50 crib sheets for every possible medical emergency. There's something both lonely and terrifying about walking down the hospital hallways in the dead of night, knowing that if something bad happens, you're it. One side of my brain is galloping through every possible catastrophic scenario, while the other side is working on a kind of cardiac serenity prayer to every heart in the entire hospital. May you keep that beat nice and steady for the next 12 hours. No funny stuff until my shift is over. Then, the PA system blares overhead. Code 411, cardiac arrest, 16 West. Here it is. The first code I'm in charge of. Shit. I race down the hall and burst into the room breathless, throat parched, pulse pounding, and then my brain splinters into complete and utter blackness. Say something. Anything. Chest compressions. Keep back in the oxygen. Well, any idiot knows the basics for keeping someone alive, but what next? Did you shock first or give epinephrine? All those training courses had seemed so easy back then, so ridiculously simple on those ever-forgiving mannequins. But now there's someone real, someone alive, though perhaps not for much longer with me at the helm. I can't remember anything. Someone presses an EKG into my hands, and I stare at it for the answer. And stare, and stare, and stare. Zigs and the zags seem to melt into a jumble of Sanskrit. Think. Okay. The T waves. Maybe the T waves looked a little peaked. Peaked T waves on an EKG indicate elevated potassium, hyperkalemia, except when they don't, and except when they look peaked but aren't actually peaked. These kind of look peaked, I'm thinking, but maybe it's just repolarization, or maybe they're just big. I could inject the concentrated IV calcium to treat the hyperkalemia, but I'm so scared I'm going to be wrong and then really screw things up. Who's in charge here anyway? A cardiology fellow blusters his way into the crowd, clearly seeing the mess for what it is. I give a little nod, and then there's an embarrassing moment as we recognize each other. We were in the same med school class, same circle of friends even. But I'd taken some years to do research, so he was now a cardiology fellow while I was still a medical resident. He bites back his obvious criticism and looks in at the EKG. Peak T waves, hyperkalemia, let's get some calcium, he announces clearly. Though not derisively, an act of humanity I only really appreciated years later. The patient did all right in the end, or at least survived the code. But I was mortified. My first night on call, and I almost killed a patient. I slunk off afterwards, hoping to disappear myself in the sea of white coats. I was furious at myself for getting so paralyzed by fear that I couldn't run the code. What had happened to all of my training? What made me the angriest, though, was that I actually gotten it right. It was hyperkalemia. Those T waves absolutely had been peaked. I could have called it on the spot and been the model of a take-charge doctor. But I couldn't get beyond my gripping fear of getting it wrong, of killing the patient, of looking like an idiot. Now, I usually give lectures to other doctors, but I've sometimes told this story to lay audiences. And I'll tell you, this is not what patients want to hear. They don't want to know their doctors are scared witless. Now, if this paralyzing fear only happened to those few deadbeats who somehow slipped through the med school application process, that would be one thing. But the truth is, it happens to nearly everyone. Just ask any nurse or doctor you know, and they'll tell you, perhaps more than you really want to hear, about their moments of fear. There's a famous case of a woman who had brain damage to her amygdala, such that she did not experience fear. Researchers brought in snakes, they set loose spiders, they made her watch a double feature of The Shining and Alien, and she was completely unperturbed. As a medical student, I wanted to be her. Fear is a primal emotion in medicine. It may be most obvious in neophytes, but that's just the first link in a chain that wends its way throughout the lives of nurses and doctors. It may wax and it may wane, but the fear of harming your patients never goes away. It's inextricably linked to the practice of medicine. Now, I sometimes compare notes with friends in the business world and ask what their worst fear is. It's usually something like, losing a big sale, making a bad trade that could inadvertently bring down the world financial system. And I have to restrain myself from saying, "That's it? That's all you're afraid of?" I remember when I first read Ernest Becker's classic book, The Denial of Death. Becker posits that humans are unconsciously terrified of imminent death. And so every action we take is really just an act of denial. And this precisely captured my fears as a doctor in training, except that my fears were entirely conscious. I was actively and consciously terrified of imminent death. And if I so much as hiccuped while standing on the medical wards, I could unleash a chain of events that would end up dismembering or asphyxiating an unsuspecting patient. Now, people who are fearful like that tend to be a bit pessimistic in their outlook, and they often overestimate the risk of bad outcomes. As a result, their choice of action can lean toward the risk-averse. When I stood in front of my coding patient, my overwhelming fear was of making a mistake. So I chose what seemed to be the least risky path, not injecting the potentially dangerous IV calcium. But of course, this wasn't at all the least risky path. Had the cardiologist not come along in time, the patient would have promptly died of a cardiac arrest. When we're overwhelmed by fear like that, our sympathetic nervous system kicks into overdrive. There's a welter of emotions, and we often misread important cues. And I can remember the swell of stimuli during the code, people shouting, machines beeping, medications flying, and it seemed to cave in on my thought process, making it impossible to think clearly. Interestingly, research suggests that concrete tasks that require selective attention, like putting in an IV, for example, these can actually be improved by modest amounts of stress. The adrenaline seems to help you focus on specific, narrow tasks. But things that require divided attention, that require integrating information from disparate sources, these suffer notably under stress. Well, what is medicine if not the integration of information from disparate sources? I mean, patients don't present with a single symptom in a single square centimeter of their body. No, they have an itchy pain coming from their armpit, plus a weird rash and elbow spasms, plus they missed their cardiac meds for a week, plus they've got a cousin who's a lawyer hovering up here and a sodium level hovering down there. When we're in states of acute stress and fear, we often overemphasize the unimportant facts and end up downgrading the important ones. And you can see how in the real world of clinical medicine, fear can be a direct threat to patient safety. Now, for me, over the years, as I gained confidence with my clinical practice, my overwhelming fears receded in intensity. The moments of utter panic were fewer, but the fear was never completely absent. The thing we have to realize is that this fear is not only normal, it's also necessary. And even though as a med student I desperately wanted to be that woman who didn't experience fear, I now feel differently. We need a certain baseline of fear to keep us grounded in what we do. These are human beings we're taking care of, after all, not widgets or spreadsheets. You need a certain amount of fear, for example, when you approach someone's jugular with a 6-inch needle, or you click on an IV of a mustard gas derivative to treat someone's cancer. If we eradicate our fears completely, we become those cocky cowboy doctors, and we all know how that can play out. But we also can't live in a state of utter panic all the time. So I've had to negotiate a sort of armistice with my fears to keep them at a safe operating distance. And I kind of like to think of my fears as a left lower quadrant abscess, tucked in a corner away from all the vital organs so I can function in the day-to-day world of medicine. But it's a soft-walled abscess, not a necrotic, crusted one. So there's a baseline seepage of fear into my bloodstream so that I can function in my day-to-day work. But every so often, the abscess ruptures, and it's the fulminant peritonitis of fears. When this happens, though, we need to remember that fear is a perfectly human state for a doctor or nurse to be in. However, it's not necessarily the most ideal situation for your patient to be in. Now, the doctors we learned from, they didn't talk about any of this. The unwritten rule was to hide any fears or doubts because looking weak was the worst sin possible. What do they always say in internship? When in doubt, pretend, right? But ultimately, it's our patient's welfare that comes first. Being strong means accepting fear as the everyday cost of being human. And medicine, despite all the sexy technologies you hear about in these TED Talks, medicine is still fundamentally a human endeavor. Being strong means turning to your colleague and asking for help, even to take over while you step out and catch your breath. In 1926, Dr. Francis Peabody gave a lecture with a now famous phrase. He said, "The secret of the care of the patient is in caring for the patient." And I would take that one step further and say that the other secret in the care of the patient is in caring for the caregiver. Rather than pretend that we never experience fear, we'd be better doctors for our patients, better nurses for our patients, if we admit that we do experience fear and give ourselves the breathing room to recover. Owning up and asking for help, it's awkward, it's embarrassing, but it's the most honest, ethical, and safest thing to do. I'll always be grateful to that cardiology fellow who stepped in that day and helped me with my first coding patient. And I suspect that the patient was probably pretty grateful too. And my payback to him is to now be on the lookout for other colleagues when they experience their moments of fear and proactively step in to help out. We can't always control when that abscess of fear will rupture, but we can control how we respond. We can resist the urge to look strong and just fake it. We can actually be strong and ask for help and keep our patients safe. And then we can forgive ourselves for the human foible of occasionally being overwhelmed by fear. If we do it honestly and safely, I think that our patients will be able to forgive us too. And that's something that no one should be afraid of. Thank you.